Hello, sports fans. This is your weekly lecture with Dr. Wengard in adult conditions. Not going to be a long lecture, but it is going to be a lecture nevertheless. We're going to talk about today obesity and the endocrine system. I'm going to touch on obesity. I'll talk a little bit about diabetes, and the rest is in your reading. So I'm going to leave most of it to your reading. But I just wanted to touch on a few things as I walk through this PowerPoint. A lot of the PowerPoint is self-evident. You can just read through it. Those are highlights. A lot of that's in your reading. There's some additional stuff though that's nice to go through. So I want to talk about obesity, and you already have picked up on that. Obesity is a big problem in the United States, and it is a big indication of our lack of being healthy. And I always joke about how difficult it is to be in good shape and be in good health, especially as you get older in America, because there's such a cornucopia of snacks, and it's a wonderland. It's a wonderland. Snacks, food, carbs, sugar. I mean, it's difficult to avoid, and our food industry has become that way. It's just sugar and carbs are the thing, and they're cheap, they're widely accessible, and they're yummy. So you may not be able to see this very well. The lighting in here is a bit all over the place. I can't get a great lighting here for your PowerPoint. Go through the PowerPoints along with me if you want to. So that's probably a good idea. But obesity is just a big problem in America. We have, I feel like, two Americas. One very focused on fitness, very focused on health, and one that's very obese and unhealthy. And even if people aren't obese, there's a lot of unhealthy, non-obese people running around in America. Okay, so I'm already doing this because I'm more struggling with this as a 55-year-old. But anyway, obesity. You will see a lot of your patients who are flat out just unhealthy, and they are obese. And you'll see the scale here. Obesity doesn't take a lot to be categorized as obese. If you can see this very well, when you take your BMI, your body mass index, and you figure out, with your weight and your height, where your body mass index is, and you'll see that it doesn't take much to get into the overweight category. So your illustrious professor, Dr. Scott Wengard, I did this just the other day. I did this I had this handheld device that the public health program has, and I did the old calculator here that's in one of the slides that you can do. You can calculate your own BMI. But I did it, I calculated my BMI, 26.4. This lean, mean fighting machine, this lean, mean teaching machine, at 55 years old, works out multiple times a week. When I say multiple, I mean like twice, 3 times, whatever. It's 26.4, and I fall in the yellow, the overweight category. Ouch. Yep. So something good to teach your patients, how to figure their BMI and what that means, and what being obese puts you at increased risk for all kinds of things. You're at increased risk for developing diabetes, having coronary artery disease, and which leads to, what that leads to, CVA, heart problems, et cetera, et cetera. So just being overweight, especially carrying it right here for men, puts you more at risk for various conditions. And I would also say, as an occupational therapist, I don't think in your reading anywhere, I didn't see it, one of the things that's just tougher to carry around a lot of weight. So if you have when you have a patient who has a pneumonia or congestive heart failure or what have you, and they've been hospitalized, now they're weak from pneumonia. Let's stick with that. They're weak from pneumonia, they're deconditioned over just being in the hospital. They've become weak over the last 2 or 3 weeks. It's amazing how quickly a person, of any age, but especially over the age of 50, can become deconditioned, and they're weak. So think about how weak somebody can be. Now, think about that person being 50, 60, 70 pounds or more overweight. So they're carrying that extra weight around, and now they're weak. They were fine. They were able to get up and down out of a chair or get up and out of bed, but it still took some effort. It shouldn't take you a lot of effort to stand from a sitting position. It just shouldn't. It shouldn't take a lot of effort to sit up to the edge of bed from a supine position and then stand. It shouldn't take a lot of effort if you're healthy, right, and strong. But somebody who is overweight, all in their normal condition, it's an effort to stand up and walk. It's an effort to reach down and put your socks and shoes on, and they're short of breath already. They got this belly in front and in the way. That belly is in the way. I wanted to point that out to you. So obesity is extra weight to carry around, and when you're weak, it's that much more difficult. I have had the thought so many times, and I've talked about this with patients over the years very delicately. If you lost weight and you were at the weight you should be, it would be a lot easier to get around. And now you're weak, and now it's tough to carry that extra weight around, so it makes it worse. And a lot of my patients have had big bellies, and that belly is just it's in the way. It's just in the way. There's nowhere else to say it. I can say that to you. And I've had patients point that out to me. Man, if I didn't have this big gut, I could do this or I could do that. Yes. So obesity, it isn't something I make fun of people for. It's a very big challenge. It's a very big problem. And it's something that you're going to encounter every day as you interact with your patients and try to serve them and help them be more independent, more safe with everything they do. So helping them become more healthy is just huge. And that includes, for a lot of our patients, losing some weight, right? Eating. What are you doing? What are you putting in your body? Right? What are you eating and drinking? What are you smoking? What are you putting in your body? And what are you doing with your body? How active are you? And, I've also had this. My patients seem to say, this is just me in my practice, an observation that I've made. I've got no research to back it up per se, although I've done some research and I'm kind of writing an article on my community health study. But my experience has taught me that most people think to be healthy, they have to quote unquote eat healthy and they have to quote unquote exercise. Well, a lot of people don't want to exercise, so they may or may not eat healthy, and so that they don't understand the impact of activity on their health, okay? So I teach all the time, you don't have to exercise to be healthy, but you do have to be active. And that's where occupational engagement comes in. What do you like to do? Reading is not an active occupation. It's a sedentary occupation. It's great for the mind, but it's not great for the bod. Let's get this bod moving and doing stuff and engaged. If you're sitting more than you're standing and doing stuff, some of our patients can't stand, so they need to be as actively engaged in occupation as possible. And it brings so much more than just burning calories, but it does burn calories, and the more active somebody is, the more healthy they eat. I found this to be true with me. I like to run, I like to work out. Well, I like to run, I don't like to work out, but I do it anyway. And I found when I work out regularly, consistently, I eat so much healthier. When I go through a period when I'm not as active and I'm very sedentary, I don't eat as well. I eat crappy. And my patients are the same way. So I can relate to them, not only now that I'm older, but I can relate to them because we're the same. We're humans. This is very normal. So get your patients to eat healthier, talk to them about their diet, talk to them about nutrition, and also talk to them about active occupational engagement and what that means to their health. I wanted to mention that today. Okay. You can read, these are some good websites to go to. The CDC has a great website, oklahoma.gov. There's some great websites there I want you to review and know and peruse. I wanted just to bring your attention to these two tables in your reading. Be familiar with those types of things. Bariatric surgeries, gastric bypass and bariatric surgeries became very, very commonplace. And I started seeing more and more patients that had complications due to bariatric surgeries, bypass, gastric bypass or what have you. And they had people, I don't know, just wanted to lose weight and be healthier, and they thought this procedure would be it for them, and they suffered big time. So anyway, I just wanted to draw your attention to that and talk about diabetes. For some reason, and probably for good reason, diabetes and obesity are commonly connected. People that are obese are more at risk for diabetes, it seems like. But there are a lot of people who are diabetic who are not obese necessarily. So diabetes comes in two types. Type 1 is basically your body's inability to make insulin, and insulin is that hormone that is secreted by the pancreas that helps get that glucose out of your blood into your cells, so your cells can use it to make energy. So insulin is important. So my patients with diabetes don't know that. They know it's important, and they know that it has something to do with blood sugar, right? It controls my blood sugar. That's what people say. What does insulin do for you? Why do you care about insulin? What happens when your insulin's low, or your body? Well, then insulin controls my blood sugar. In a way it does, but in a way it doesn't. That blood sugar glucose is in the blood, and insulin helps get that glucose to the cells so that the cells can use it to make energy. When there's not enough insulin produced, then that glucose doesn't get to the cells that need it, and it's just in the blood, right? So that can be dangerous stuff. So anyway, that's a good way to educate your patients. A lot of times your patients don't. They get the connection to some degree, but they don't really understand it. So it's good to take the time to instruct them on simple things like that. So we're going to see a lot of patients in Oklahoma and around the country with diabetes. It's a very big problem in the Cherokee Nation, the Native American population. Native Americans are more at risk for developing diabetes, and the Cherokee Nation, of course, is really tracking on it. They're really out in front of it. They're trying to do as much as they can to help tribal members, at least, to take control of their health and overcome diabetes. So know that normally you won't see patients that have diabetes as their primary diagnosis. Like other things, you usually will see somebody that for something, and they have diabetes. They were recently hospitalized with a CVA or with pneumonia or whatever, and they have diabetes. So people may have, it's a complicating factor for sure, and it impacts how we treat them because it really impacts their health. So you need to know that your patients have these conditions. Even though you're not seeing them for those conditions, it's good to know that these are comorbidities, we call them, and that they have these because it's part of their overall health. And it may be why they had the fall, right? And maybe their blood sugar was low, they were walking, stumbled, tripped and fell, fractured their radius or their humerus or hip or whatever, So it's important diabetes is a huge part of their overall health, and we have a nice role to play in helping them take control of their health and manage their diabetes. Children can have diabetes and adults can have diabetes. Type 1 is, I consider that, you'll see this sometimes in medical settings, insulin-dependent diabetes. You will also see type 2 diabetes as non-insulin dependent diabetes mellitus, NIDDM. So you can see it either way. Type 2 tend to involve older adults more, but younger adults can have type 2 diabetes as well. So know that. Talked about some people will have a hypoglycemia, which is low blood sugar condition. They don't have diabetes per se. They might be diagnosed with hypoglycemia. Or they may have hyperglycemia if they have diabetes, too much blood sugar. Their insulin their pancreas is not producing the insulin, so the blood sugar stays in their blood. The glucose stays in their blood and get into the cells so the cells can use it to make energy. You've heard of gestational diabetes, which is something that can affect pregnant women, and 35% develop type 2 within 5 to 10 years. So my wife actually developed gestational diabetes with one of our babies. They blamed it on her age. She was in her 30s, so I don't know if it had anything to do with it. Age is blamed for everything. There's some stats for you. Another good website to go to. Some more good websites to go to. Some things that you're going to be seeing with people. Some symptoms that you're going to be seeing. People oftentimes when they have type 1 diabetes will just they will have to go to the bathroom an awful lot. They will eat an awful lot. They'll get dry mouth and all that. So there's some other things that you might see. Ketones in their urine, etc. I feel like type 2 diabetes is on the rise as well. So usually when somebody has a fasting blood sugar, fasting glucose, greater than 126, this is a clinical sign they may have diabetes, or they may just take a random glucose set level and it's over 200. So, I always like to ask my diabetes patients, what's a good blood sugar? And I get numbers all over the place, what their understanding of what a good blood sugar is. They might say, well, 90 or 100 or whatever, and I'm like, that's a bit low. 120 to 200, I think, is pretty, it's going to fluctuate, of course, depending on when they take their blood sugar, but so be mindful that they have diabetes, and be mindful of how often they check their diabetes and how seriously they take it. One of the things that we see with people with diabetes is that they just don't take care of it. They know they have diabetes, they've been told what to do, and they just don't do it. They're non-compliant with the instructions that they've been given, and they haven't weaved that or woven that into the rhythm of their life. They may or may not check their blood sugar frequently throughout the day. I haven't checked my blood sugar today. I feel good, or whatever. They're not what's the word? Disciplined about checking their blood sugar. They're not disciplined about their diet. And maybe they lack understanding, and we can help instruct them in that. And maybe we can just help them, sometimes they do have understanding, they just haven't structured their day. And so I'll walk through and say, let's structure your day. When do you take your blood sugar? When do you check it? What are you eating, and when do you eat it? What's your diet look like in a normal day, And what's your lifestyle like? So one of the things we can really do is help them structure their day and structure their lifestyle so they weave into the rhythm of their life, managing their diabetes. And so the nurse has been talking to them about it. They may have had a nutrition person, a dietitian, and most do not. I think like the Cherokee Nation is really good about teaching people how to live with diabetes and manage it. And the rest of us are like, we may or may not get good instruction on it, although we can find good stuff on the internet, of course. Some people are better about seeking it out than others. So that's a great thing that we can bring to the party as OTs. If they manage it well, they can have a good life. I mean, basically, if they manage it well and they weave these practices in, checking their blood sugar, eating the right things, keeping their blood sugar regulated, taking their insulin, whatever, they can have good life. And a lot of our problems come when they just don't. But some have it worse than others. So these are some complications. Imagine, having a stroke and having diabetes as well. When these other problems that can happen as a result of diabetes, they can have strokes, they can have these other things, coronary vascular disease, peripheral artery disease, PAD, hypertension, diabetic retinopathy, a diseased condition of the retina, as a result of diabetes. I believe our Dr. Hatley, our guest speaker on vision, is going to talk about that to some degree. We have neuropathy. Really is that disease condition of the nerves that die. We see nerves that aren't getting, I feel like I consider diabetes to be a circulatory problem. And it certainly has results for the circulatory system. One of the repercussions of having diabetes is a lot of times cells very distally in the fingers and toes, for example, don't get the sugar they need, don't have the energy they need because of the problem with blood sugar, and we see nerve cells die. And you'll see people with decreased sensation distally, decreased motor control, because nerves are dying and they don't have. So that's it. When they have decreased sensation distally, that's an indication that something's going on. And toes, I feel like toes are even probably worse. Toes, numbness, diminished sensation in the lower extremities often develops first before the fingers. So that's a good thing to know and to be checking for. And that's why we have issues with ulcers, which we're going to talk about. We have things that go on as a result of diabetes. So they can't feel their feet very well. They just don't feel it a little bit, and so they think they're fine. It feels fine to them. It's so gradual. This diminishing of sensation is so gradual that they get used to it, and they think they're still normal and good to go, and they should be able to feel anything that's wrong in their feet or their fingers or what have you, and they can't, and they don't realize it. And so they might get a wound of some kind and not notice it. They don't feel it like they would because they have diminished sensation. And that sore can get worse, and that's like we've talked about before, that sore can get infected, that sore can become gangrenous, and they can lose, and do often lose their feet, and amputation because of diabetes. I've got a story about that. I may have told you this, I forget who I tell my stories to, so forgive me if you've heard it, okay? Had a patient one time, a cowboy out near Jay, Oklahoma. He's a rancher, tough guy, big guy, very obese, diabetic, and I'm seeing him for an amputation, a below-the-knee amputation. Can't remember if it's right or left, it's been many years ago. And so when I was seeing him for his evaluation, I said, hey, if you don't mind me asking, what happened? I like to ask my patients to tell me their story, and they do, and they usually like to, they usually appreciate that. So he, getting older, having trouble getting around, a very heavy guy, very large guy, carrying too much weight around, and big old belly, and he's diabetic, and he has diminished sensation in his lower extremities. And his son says, let's go feed the cows one evening. And so he hops in the truck, he's in the passenger seat. It's freezing cold outside. Son's got the heater on in the floor. Patient has no socks and shoes on. He's barefoot because he's not gonna get out of the truck. He's just going with his son to keep him company while his son feeds cows. He develops a blister on his foot. The blister becomes infected. Not because he didn't notice it necessarily. He thought, oh, it's a blister, he's a tough cowboy. They took care of it, maybe put a Band-Aid on it, didn't do much with it. Because of the circulation problems that he has in his feet and his diabetes, that did not heal. So what we see with patients with diabetes, if they develop a wound, the wounds don't heal like they used to because of the diabetes. They're older, but also just because of the diabetes. The wounds don't heal, and they need more help healing. This wound did not heal. Started as a blister and didn't heal, got worse, became infected, became gangrenous. By the time they started addressing it, it was too late. They just couldn't get that wound to heal, and he ended up having his, it was above the ankles, below the knee, lower extremity amputation there. So all because of a blister from the heater of his pickup. I mean, little things like that oftentimes are what happen to our patients, and they lose a limb or something. So, oh, this slide here, I've already advanced the slide. I like this a lot. There's a good video to watch. It's a TED Talk by Dr. Peter Attia. I listened to his podcast. He's brilliant. When I listen to his podcast, I think, this guy is so much smarter than I am, okay? But I get stuff. Some of it's actually over my head, but I listen to it and I get what I can. But he has a good TED Talk about diabetes, and as a physician, he's a physician, and his prejudice against people with diabetes and who are obese, and he connected obesity with diabetes. And he's an athletic, lean guy. And then when he became pre-diabetic, diagnosed with pre-diabetes, he was like, wait, what? And so he gives a really emotional, really good TED Talk on this. So I want you to watch that. I want you to watch that video. And then that's his website. And he's got a great podcast. So look up Dr. Peter Attia. So there's a great example of decubitus ulcer that we want to help teach our patients to inspect their feet, to take this very seriously, but tell them why things happen, right? Tell them why they need to do this every day. If they understand the importance of it, the value of what you're telling them, they're more likely to do it. Same thing with the home exercise program. Same thing with the home activity program, I like to call it. If you do these activities and these exercises regularly, you will prevent yourself from becoming weak, falling, blah, blah, blah. Tell them why you want them to do stuff. They're more likely to understand it and agree to it and actually do it. So, and please, I hear people all the time, don't give a home exercise program, they're not gonna do it anyway. You know what, they might. And even if they don't do it, at least you did your part. You at least taught them what to do and why and how to do it. Whether they implement it or not is up to them. They have the right to not do that, but at least you've done your job. Don't presume they're not going to be compliant with it. Teach them anyway. Do your best, and then let them decide how to live their life, okay? More examples of what diabetes can cause. Anyway, teach them how to manage their diabetes, teach them how to give themselves insulin, teach them how to manage the medications, their metformin, whatever it is. Teach them how to structure their day, diet, activity, etc., etc. Teach them how to inspect their feet. You may have somebody who can't reach their feet. They can't bring their foot to them. They can't inspect. We have adaptive equipment, long-handled mirrors and such. We can help them not only know what to do, we can help them with how to do it and why, okay? And that's, the rest of it you can just read for yourself. And that last slide is for us if we were in class together, but we're not in class together, so. Anyway, I wanted to go through this with you, give you a short video. Have a great week.